Today I'm here to discuss a little bit about our denture technique, which involves a treatment denture prior to making the final denture. In all of prosthodontics, this is the only prosthodontic treatment that dentists are taught not to go through a provisional stage. We're even taught to do a provisional on a single crown. And one of the reasons that dentures are so unpopular with most dentists is because they're so unpredictable. Now we want to check that. The treatment denture, I'm going to give a brief overview of the laboratory preparation and the clinical delivery. First of all, we're going to place upper anterior teeth for the patient, and we've developed a technique where we place these teeth 20 millimeters down from the height of the labial vestibule and 10 millimeters out from the center of the incisive papilla. We use a little rim former paddle on the upper right to get our level, and we make our base plate exactly 20 millimeters down from the general height of the labial vestibule and 10 millimeters out from the incisive papilla. And so these teeth are set in at using that level. And when we go to the patient's mouth, we don't put a base plate on the lower denture. We do a base plate, but we don't use a bite rim, and we put a piece of what we call speaking wax. That is to develop our phonetic clearance with the upper anterior teeth. So when we go to the mouth, this initial setup of these teeth are set up with the patient not even present, and we find that in 75% of the cases, using that little 10-20 rule, the upper anterior teeth are in a satisfactory position. Sometimes we'll miss the midline a little bit, and sometimes they'll be canted a little bit, but basically the basic position is almost always in the ballpark, and about 75% of the times we never even have to touch it. So then we use our speaking wax, have the patient enunciate the sibilant sounds, 66, a lot of the S sounds, and then we take and put 2 lower incisors to represent where the lower teeth are going to go. Now we've reestablished the anterior component, and now all we have to do, we take a wax bite. This is the only time we'll do a wax bite. All of the bites on dentures are done with central bearing points. The case goes to the articulator. The occlusal plane is selected using Camper's line. Another way of doing the plane is from the incisal edges of the upper back to the back of the lower, halfway up the retromolar pad. The lower anteriors are set, and in the lower posterior on the treatment denture, we are not going to place teeth. We're going to put a little bite block. This bite block works much like a repositioning splint. It allows the condyles to reach the most superior position into the glenoid fossa. Here are some finished setups. You will notice in the center image we have a class 3 situation where the lower anterior teeth are actually edge to edge or maybe a little bit further out. In the lower right image you see a severe class 2. And it's very important that the skeletal relationship of the patient when they had their natural teeth is duplicated in the denture. On the lower right is a pretty normal class 1 setup. On the upper left, you will note the arrangement of the upper 33-degree teeth where the lingual cusps are set down and the buccal cusp is set up. This is to help us lingualize the occlusion. Now the treatment denture is going to be processed, but in the processing we are going to place a space between the tagular surface of the denture and the cast. So here they are invested in some of the old hydrocast flasks, and we use a Dow Corning product, as you can see. We use a dental catalyst to set it up, and we apply on the upper images. You can see that there's a spacer applied. These dentures are processed, they are remounted, make sure that we take care of any processing errors, And then these dentures are placed in little reline jigs. These little jigs that are pictured here are not available anymore. We use inexpensive little articulators. Sometimes we'll use just plain old reline jigs. Now, here are the old hydrocast jigs with the dentures in place. Now we're ready to see the patient. Now, the initial placement of the functional impression material is done on the jigs before it goes into the mouth. This controls and maintains the occlusion. So here we are at the chair, and with our jigs and the treatment dentures. We're going to put the treatment dentures over into a little vat of warm water. We put the jigs into a vat of warm water. This water has some wetting agent in it. It's something that Sultan makes to make the water slippery and to keep the hydrocast from being so sticky. Those casts on the jigs are coated with an Al-Coat tinfoil substitute like Al-Coat, some material like that. Then we use a material called microseal. Microseal is placed into, it's mixed as according to the manufacturer's recommendations, and it is placed in the lower denture to hold the vertical dimension and refine the occlusion. And this is very important. This is something that we worked out over several years. The microseal is soft, and when it's totally set up, it is about the same consistency as hydrocast that is pretty firm. Mature hydrocast, we say. So we put the microseal in the lower denture and put it into the jig that maintains the occlusion. Sometimes we'll take and put a little spot of microseal in the palate of the upper denture. A patient that has a tremendous strong bite could move that hydrocast in the first 24 hours and change the occlusion slightly. So now here we are with the microseal. We trim the excess back, and the microseal's in the lower denture, and the microseal's in the palate of the upper. Now what we're going to do is mix our hydrocast, and I always mix the hydrocast 1 1/3 powder to 1 vial of liquid. We let it get to about the consistency of honey that's been on the back porch in South Carolina wintertime. Place it into the treatment denture. The treatment denture goes back onto the jig, and the jig goes back into the warm water solution. After about 3 minutes, the denture is taken from the water and off of the jig. If we have any places where there's not much hydrocast on the peripheral border, we'll add a little bit, and into the patient's mouth it goes. At this point, we leave it in about 4 minutes, and we take it out, and we begin to see our functional impression. But on the upper right image, you see a place where the denture is gouging into the patient. We can't let the patient go home the first day with that. So we take it back to the lathe, and we will adjust that part of the denture base that's protruding through the functional impression material. Now, on the first day, we try to refine the occlusion. We use a green occlusal indicator wax. It has a sticky side to it, and it comes with a little grease pencil. So we put the little occlusal wax down onto the posterior bite block of the lower treatment denture. And notice it's very easy to hold this denture now because we don't have hydrocast in it yet, and it's not sticky. Place this into the patient's mouth, ask the patient to close on their back teeth, and give us a squeeze. So when we take it out, we will see some areas, some of the upper lingual cusps are penetrating the wax more than others. We take our little grease pencil. The lower left image shows me marking the heavy points of the occlusion, and on the lower right image you can see using a greenstone we adjust these areas. Now, when the patient leaves the first day, we have the occlusion pretty much balanced, but you notice there's no contact of the second molar, not at all. The upper second molar, the lingual cusp, is not hitting our bite block at all. Then what we do is we strip the microceal out of the lower denture, except that microceal that is on the crest of the ridge. This will keep the patient from chewing hard, and this hydrocast is really the only true functional impression material that there is in dentistry. And this stuff will flow, sometimes it'll flow up to 5 days, but the first 2 days it flows pretty readily. Then we place our hydrocast into the lower denture with the microceal left on the crest of the ridge. Put the denture back onto the jig, back into the water, and then into the patient's mouth. And on the lower right image, you can see where the microceal is maintaining the occlusion, and the borders are beginning to be formed in the hydrocast. Now, here's our second day. This is 24 hours later, and notice there is now contact evidenced by the occlusal wax into the second molars. It's very important to understand where this contact came from. This contact came from the fact that in the first 24 hours, the patient's condyle seated fully into the fossa. And the occlusion on a denture is the most important thing that we have to do. Everything else is secondary to the occlusion. So we use our wax. We continue to refine the occlusion, making sure that all of the upper lingual cusps are hitting evenly. And on the lower right image, you'll see I'm actually adding a little self-cure acrylic to build up one of the spots on the lower bite block. We continue to work with the occlusion. We continue to use the occlusal wax. And on the third day, we do the last little bit of refinement. Last little bit of refinement there with the wax. And here we have all 10 lingual cusps only. In the lingualized occlusion, you'll have 5 lingual cusps on each arch, each quadrant. On the 1 lingual cusp on each bicuspid, 2 on the first molar, and 1 on the second molar. And so you know I made a little funny there. I said this doesn't get any better. Well, maybe a Budweiser. Now here is day 2 with the functional impression, and you can see on the lower left, you can see the areas where the hard acrylic is poking through the hydrocast. Now they were not there 24 hours ago, but now they are, because the hydrocast has molded itself to the dictates of the muscle. And on the upper right image, you can see we've got a lot of problems with the lower. We're overextended. We have pressure spots in the front. And we'll coat this hydrocast with a little bit of all coat, tinfoil substitute. And we'll go back into the laboratory, and all those places that are marked will be adjusted very liberally. As you can see in the upper left image, we've adjusted those places. We've also got some places where our denture base didn't go down far enough. You can look in the lower left image. You can see the hydrocast wants to form its border way lower underneath the tongue than our denture base was processed at. So we have to add self-curing acrylic. And this is what we call a backup, because that hydrocast that is extended into the proper place in the lingual tongue form, you couldn't even pour cast in that without distorting that impression. So this is what we call a backup. Now, at the third day, we are pretty much finished with the beautiful functional impressions. We'll get down to the nitty-gritty. We'll start studying this thing. We'll start feeling around the outside for any little sharp extensions. On the upper left, you can see where I'm looking at the little border of the microceal needs to be trimmed down, because it's a little bit different level than the hydrocast. At this third appointment, we'll put a wash in that, and we'll reappoint the patient for several days to do our finalization. And so comparing the patient's dentures that they were wearing with what a functional impressions look like. Now, getting this type of functional impression is just the it's the cream on the cake. If the occlusion were right and everything else were right, a patient could tolerate a denture like the law. But with the type of impressions that we get in my practice, I can tell you that 80% of the finished dentures we never even have to adjust. The day we place the final dentures, we give the patient an appointment for 2 months. 1 out of 5 will call before the 2 months is over. Now, how do we handle flabby anterior tissue? We've got tissue that's flabby because the patient has lower natural teeth and the occlusion has not been stable, meaning that the lower anterior teeth are occluding with the upper anterior denture teeth. And what we do is we get our basic functional impression with the hydrocast, and then we go and we just hollow out inside of that impression, as you can see in the upper images, and we put hydrocast in that is absolutely watery. We place it in the mouth, and we actually will capture that flabby tissue without compressing it. In the prosthodontic texts, you see tricks where they make an impression tray with a hole in it, and the impression is painted over that tissue rather than taking an impression of it. But this is a great way of doing it. One of the tricks that you can tell that the tissue, flabby tissue, is being compressed. If you push that denture up, that denture will come pushing back down at you. You're going to get a little movement of the denture, but not much when that flabby tissue is, the impression is obtained with the flabby tissue not compressed at all. So here we are. We had to add a little bit more to it, but we're basically finished with this functional impression. And so here are some other cases comparing the dentures that the patient was wearing with our functional impressions using the hydrocast. Here's another couple. These are not the same patient. Look at that lingual extension we have on that lower. And we a lot of times put a Dentsupply Lucisoft. And that Lucisoft goes in those undercuts, and you got to have a crowbar to get that lower denture out. But not if the occlusion is not right. Here's another couple of functional impressions. Finalization. Once the treatment denture is fine, you're home free. As a dentist, all you've got to do is take a face bow. We mark the vertical dimension by putting notches in the interdental papilla. We put a little pothole in the interdental papilla. Have the patient close in maximum incrustation, and we measure that measurement and record it, because all denture bites, other than the first wax bite, is taken with a bearing point, and they're always taken at an open vertical. By measuring this vertical, we know, the technician knows where to close the articulator to after he gets the case mounted. Now, here's the Cobo balancer. We place the striking plate on the lingual flanges of the lower. We hold the denture in a maximum incrustation and attach the pin to the palate of the denture. We blacken out the little striking plate, and we go to the mouth and we attempt to do a Gothic arch tracing. Many times the patient does not have the manual oral dexterity to move their jaw around. We'll give them little tricks like your chin is at the home plate, and move your chin out to the pitcher's mound, and then move your chin to first base, and then move your chin to third base. Some people just can't do that. And on the upper right image, you notice that we only have a straight mark back and forth. That's the only thing we could coax that patient into doing. So when the pin is on the top, the point of the tracing closest to the front of the lower denture is the most protruded superior position of the condyle. And in that we take and put a little notch. These little striking plates are disposable. We put a notch at the apex. We lock our patient into it, and we squirt our polyvinyl siloxane between the teeth. And this is all that the technician needs. He's got his tooth position, he's got his final impressions of face flow, the bite, he knows what the vertical is, and these things will be mounted. They're boxed and poured, and we don't freehand pour these things. We still use boxing plaster to box these impressions and mount them, and then we make stone cores, and then we cross mount. We make duplicates of these dentures by the use of alginate impressions, and we cross mount everything. It's the same thing as having a 6-unit bridge. When you've got a mounted model of the approved temporary, which is cross-mounted to the model of the dies. And so we have the same thing in our denture work. If we're not going to do any changes from the treatment denture to the final denture, many times, especially if we have an out-of-town patient, we don't even do a try-in, unless there was some question about the bite when we did a remount. When dentures are delivered, if that patient comes back for the second adjustment, we automatically do a remount. And a remount is done exactly the way we did the finalization, by taking a face bow, putting a bearing point on there, and taking the remount and put it into the articulator. And many, many times you will find that it's the occlusion causing the sore places. And as far as relines are concerned, I think that most relines are done in this country for the wrong reason, because the dentures are loose because of the occlusion and not the way the denture fits the edentulous ridge. Well, I have a statement here I made. I didn't even know this was on the end here, but I will read it if I've got a few minutes, right? There are as many as 40 million totally edentulous and partially edentulous people in this country. The senior citizens are the fastest growing segment in the population, and they control more money than any group in the history of the world. Artificial tooth production is at an all-time high. It has been estimated that 2 million denture teeth are manufactured every week, and with many companies, workers doing this for 24 hours, 7 days a week. I think that removable prosthodontics is the most lucrative area in dentistry today. Those who can restore the mutilated mouth are in the driver's seat. However, our dental schools have put removable on the back burner. Graduates are not trained in the basics of central bearing points, central relation, removable occlusion, mucostatic impressions, functional impressions, partial denture design. Making a functional and comfortable distal extension partial is a lost art. A really good denture made up front makes implant retained prosthesis predictable. You must know how to do a denture first. Most dentists have no desire to treat the mutilated mouth. What a shame. Thank you.